bit or even a lot about this stuff, but I thought I'd go through it just once because it actually frames how primary care folks think about how to treat infectious disease. You know, the trick about infectious diseases we were just talking about is that there are some infectious diseases that go away by themselves. Most infectious diseases go away by themselves. There's some infectious diseases that need antibiotics, and there's some infectious diseases that will kill you. And the challenge is sorting out one from the other, making sure that the ones that will kill you and kill you soon get to the hospital and get IV antibiotics, and then making sure the ones that didn't need antibiotics anyway don't get them, because the more we use and overuse antibiotics, the less effective those antibiotics are for the people who need them most. So, you know, infectious diseases go from the common cold to urinary tract infections to sexually transmitted diseases, to sore throats, and pneumonia, and bronchitis, and bacterial endocarditis, appendicitis, diverticulitis, hepatitis, meningitis, ear infections, sinusitis, gastroenteritis, and a bunch of others. I left out cellulitis, it looks like, but you know, a lot of things we see commonly are infectious diseases. About a third of all primary care visits are likely for these kinds of illnesses. You know, as I said, about a third of back pain, a third of infectious diseases, and probably a third are allergies. I have the exact numbers incorrect, but that's probably a pretty close guess. You will recall that bacteria are free-living single-cell organisms that aren't plants or animals. They have the ability to reproduce, and unfortunately reproduce in the body, are all over the place in the soil, in the water, and in our food, and that's why, you know, like you can't eat lettuce this week, because they wouldn't get contaminated with E. coli.
This was the week I was going to start eating lettuce.
You know, it was about time, that's right. I'm trying to eat this week, and it ain't working. Bacteria cause human disease, invade and reproduce in the human body, and compete with vital organs for oxygen and nutrition. So our problem with them is that they compete and they begin to sort of invade and digest various human organs. The immune system is usually effective against most bacteria. That system detects them, identifies them as foreign, attacks them, and destroys them mostly before they cause disease. But sometimes they multiply before the immune system gets cranked up. Anybody have any sense of how long it takes the immune system to get fully cranked up in the case of a bacterial illness? 7? Pretty close. It's actually 9. There used to be, well, I'll say that in a second, but we used to know about, in the days before antibiotics, they used to describe something called the crisis that would come in about 9 days as the bacteria would keep growing before the immune system was cranked up, and at 9 days either you lived or you died because we didn't have any way to kill the bacteria. So 9 days used to be the sort of dividing point. It doesn't mean that every bacterial illness follows that time course, but the rule of thumb is sometimes the damn bacteria gets ahead of the immune system, and that's when you need antibacterials. Bacteria typically present with fevers, when those diseases present with fevers, shaking chills, and infection of specific body locations, like, you know, meningitis, and bacterial infection of the meninges, the lining of the brain, urinary tract infection, pneumonia, infections of the lungs, pharyngitis, sore throat, infection of the throat, cellulitis, etc. Fevers, chills, headache, and fatigue is actually usually caused by the immune system's activation and not by the bacteria themselves. And in many ways, the existence of fever is a protective defense. It's not a disease in itself. So, you know, patients often think, I've got a fever, can you do something to make my fever go away? And my response is, that's the body fighting off the bacteria. Don't be scared of the fever. You know, sort of do something about it only if it makes you uncomfortable, really uncomfortable. But by and large, let that fever lay because it actually helps you fight off the bacterial illness. As I said, these diseases can usually be effectively treated by antibiotics, but if left untreated, bacterial disease may spread to sepsis, shock, and death. That happens thankfully rarely now because we have antibiotics, and it's also worth understanding that it doesn't happen to everybody. Often people fight off the bacteria by themselves, and if you can do that, then fully for you at the end of the day. It's better not to use bacteria when you don't need them. So when you guys were all growing up, we used to give everybody with an ear infection a antibiotic. Now we mostly say, unless a child has some other reason for doing it, we mostly say, wait a couple of days, the ear infection is probably going to go away by itself. Here's a prescription for the antibiotic if it doesn't go away by itself, but wait for 2 days or 3 days and see if it gets better, because if you don't need an antibiotic, you're better off remembering that antibiotics themselves have a fairly significant use of allergic reaction and side effects like diarrhea and other sorts of things. So the art, as it is in many places, in many parts of what we do, is to use the antibiotics when you need them and don't use them when you don't, because they can make trouble, not just cure trouble. So most bacterial illnesses need to be treated within a few days, usually not within a few hours to present their spread, but bacterial meningitis is the exception. It needs to be treated as soon as possible, and obviously sepsis also requires urgent treatment, and by sepsis usually we mean widespread spread by bacterial infection associated with hypotension. Widespread, shaking, chills, and hypotension is sepsis until proven otherwise, and that needs urgent antibiotics by then. So viruses actually are in general different. They're not formally living, they're just little snippets of genetic material that find their way into cells and get those cells to reproduce the viruses. The immune system helps defend against the viruses as well, and usually does a good job at that, but sort of the battle rhythm of viruses, sometimes they take over, get everywhere, make a zillion copies, dump those zillion copies into the blood, and when those zillion copies get dumped into the blood, that's when you have, the fever and the, achiness. Viruses are more fever, achiness, and headache than they are shaking chills, but viruses can cause shaking chills as well. So the flu, which is a viral disease, is sort of the archetypal virus that, is easily spread, gets everywhere fast, you start to feel a little achy, and then a day later you feel like you can't stand up. A cold works that way, only with less intensity, but that's kind of the range of what happens. Viruses get released in waves, and those waves, that wave of viral release is what makes you feel like crap. Because viruses aren't living, they're actually harder to destroy. Because they're small, they exist in blood and air and water, and remain dormant until they're released into the human body. So, there are a lot of viruses that spread in the air. That almost never happens with bacteria. So coughing spreads viruses. Coughing doesn't usually spread bacteria as easily, but there are lots of viruses that are way easier to spread, and that's why we're so cautious about the flu in the winter, because it's so virulent and so easily spread. Measles turns out to be an unusually easily transmissible virus. So we get all uptight from a public health perspective as soon as we hear a case of measles, which, my guess is most of you have never seen, because I've only seen 1 or 2 cases at this point. Viruses as a group are very effectively protected against by immunization. But the good news is, that Ebola, which is a virus, despite what we all heard, wasn't as easily transmissible as measles was. It didn't move through the air. there the way measles does. I mean, you know, with measles, if you have somebody with measles who's in this room and leaves, and you come into this room 20 hours later, you can still get their virus from the air. Ebola turned out not to be that transmissible. You kind of had to be involved with the exact, you know, the saliva or blood or other body fluid of a patient, and if you were or touched the body or the skin of somebody with Ebola, if you didn't do that, you actually were at relatively low risk. But if Ebola had been as transmissible as measles, we would probably not be having this conversation today. And what we all live in fear of is the infectious disease that's going to put those two characteristics. You know, Ebola killed people pretty quick, it wasn't transmissible. Measles doesn't kill people that quick, but is transmissible. But one of these days, just because of how diseases work, some virus is going to figure out how to do both, and then we got to be ready to go, because the world is really going to depend on us if human beings are going to survive. That bad disease is out there someplace. It hasn't evolved yet, but the moment it evolves, we've all got a whole different level of work to do. So viruses are associated with less fever and more generalized illness. Some come and go pretty quickly, but some develop slowly over years. The ones that come and go quickly are the cold and influenza and various kinds of viral gastroenteritis. The ones that take a long time are hepatitis B and C and HIV. And the ones that come and go over weeks are mononucleosis, viral pneumonia, and viral meningitis, all of which exist at the same time. And at the end of the day, our challenge is sorting out which is which and making sure people get treatment for the ones that are dangerous in the emergency department, and making sure that people who have kind of run-of-the-mill infectious diseases get those treated in the primary care world. Viruses that come and go quickly usually require no treatment. There is treatment for the flu, but you heard it here first. If you haven't heard it here before, it doesn't work very well. You know, it's a $150 medicine, maybe more now, because the wonderful pharmaceutical companies keep jacking up the prices. But it's only effective if you start it within 36 hours of the onset of the disease, and that it only reduces the duration of symptoms by 1 day. That's the whole big treatment for flu, which is why many of us don't think it's worth doing most of the time. The treatment for viruses that develop over years is frequently complex and expensive. That's HIV and hepatitis C. I think they've brought down the treatment of hepatitis C now, and now it's only $60,000. It started as $84,000 for 8 weeks of treatment. How we all tolerate that is a question I haven't answered, but that's something that all of us ought to be concerned about and be pretty mad about and to change, because this is crazy. And this is part of what makes this whole thing so expensive as well, that people are basically profiteering. Viruses only rarely require emergency treatment. And the role of primary care clinicians is to identify bacterial illnesses, treat those, and then make sure that viral illnesses aren't treated unnecessarily with antibiotics. I can't tell you how many patients come into a primary care office and say, you know, I got a sore throat, I need antibiotics. Whereas I would say the people who walk in with a sore throat, you know, 1 in 10 needs antibiotics. And I'm going to tell you in a minute how that works. But I just want to remind everybody about bacterial meningitis and bacterial meningotoxemia. It's an overwhelming infection that can kill somebody within hours of its presentation. When it's present, and hopefully it's present rarely, it often leads to amputations. It's a long ICU stays, septic shock within hours. It's got this classic petechial rash. That's what the rash looks like. So that rash plus fever is do not pass go, do not collect $200, get to the ED as quick as you can, and tell them that you're coming so they can have the antibiotics ready to go. When I was in private practice, I used to keep antibiotics in my office, IV antibiotics, because, you know, I was always ready for this. The moment I saw it, I was ready to give somebody a dose of the right antibiotics. IV push while I was waiting for EMS to come, because that's what it takes to save a life. The mortality rate is between 10 and 40% in the United States, so 10 to 40% of people who get this die. In developing nations, it's 90%. This is a bad infectious disease. This is the bad infectious disease that we fear. The good news is there's a vaccine against most of the subtypes of it. So most people now, most of the college kids are vaccinated. It occurs classically on college campuses and among military recruits. You know, and like I say, if you hear it or see it, you know, if you even think you hear it or see it, don't pass go, don't go up to $200, scoop and run hot, because this is trouble. And it's trouble that only antibiotics and an ICU stay can fix.
What's been, like, how contagious is that?
It's hugely contagious.
Now, is that just through, like, air contact or that? So
Air contact.
if we take someone that
You
has meningitis,
If you take someone and reconfirm their meningitis, you're gonna get a call from the Department of Health, putting you on prophylactic antibiotics within 24 hours. That's one of the things the Department of Health does. We track those people down and get them started on prophylaxis with rifampin. And that is we don't have to think twice about it, we do it by reflex, because it's really important. However, most of you have been vaccinated against it, so the likelihood of you contracting it is very small. You know, it's the people who aren't vaccinated or the couple of subtypes that aren't in the vaccine that we worry about. But we will often prophylax people waiting for the cultures to come back because we don't yet know which subtype caused the disease. You know, there have been a couple of outbreaks in Rhode Island. We had an outbreak at PC about 4.5 years ago. And we got everybody at PC vaccinated inside of like a couple of days. We kind of ramped everything up and got moving because we didn't want to mess around. We had to get vaccines flown in from Europe. You know, it was high drama for a couple of days. But you know, thankfully we don't see it very much because the vaccine works. But it's the thing that that I get scared of. Bacterial pneumonia occurs often with influenza and is actually the cause of death of most of those 30 to 60 to 80,000 people. Anybody know about the great influenza epidemic or pandemic of 1918, 100 years ago? It was a great influenza pandemic 100 years ago. It killed 500,000 Americans, and it killed 50 to 100 million people around the world. It's considered one of the most deadly natural disasters that's ever happened, and it happened just 100 years ago. And most of the deaths were probably not from the influenza itself. They were probably from staph pneumonia, or many of the deaths were from staph pneumonia complicating the influenza. That said, influenza itself can kill people just by itself. So we had 185 deaths last year in kids from influenza, and they were mostly directly the influenza pneumonia, a viral process killing those kids. Usually we get 100 to 130 deaths a year. Last year it gets tougher. And you know, I'm afraid that we haven't learned much in terms of getting more people vaccinated. I don't have the sense that we've got more people vaccinated this year than we did last year, which is something that I'm not a happy camper about. Anyway, so pneumonia kills 30 to 60,000 Americans. The time course to death is 8 to 9 days untreated, which means for most people, you know, pneumonia doesn't require hospitalization and doesn't require antibiotics. That's not true of anybody over 65, and that's not true of any child under 6 months of age. You know, those guys actually all need hospitalization and IV antibiotics. But people, you know, sometimes if you have a chronic disease, we are more careful and put people in the hospital. But if you don't have, you know, if you're basically a well person with pneumonia, outpatient treatment is fine. It's sometimes hard to differentiate bacterial pneumonia from viral and mycoplasma pneumonia without lab and x-ray. And it's always worth us being thoughtful about whether there's an underlying cancer as one of the risk factors for the pneumonia. But with an X-ray, in an otherwise healthy person, we can take care of most pneumonia. Pneumonia is often called the old man's friend, used to be called the old man's friend. It was the way that elder people who had become frail would leave this earth. And that's just, that's that 9-day, you get sick and you die. Red flags, higher persistent fever. And by fever I mean higher than 150, longer than 3 days. Hypertension, immediate red flag, that's sepsis. Elderly people and infants, any evidence of respiratory compromise, and I measure that by a SAT less than 95. But fever associated with difficulty breathing or wheezing, I think will often be an ED transport as much as it will be, we'll manage it here. But it is, infectious diseases are real things, but we take care of most of them in the outpatient setting, with only a few really needing hospitalization. Some little, what we call clinical pearls, most coughs, runny noses, sinus headaches are caused by allergy, not by infection, despite what people think. True sinusitis is really rare. I've almost never seen it. Most people who have sinus congestion have allergies. Real sinus infections, I see 2 a year. That's it. Colds caused by viruses last 3 to 4 days. If symptoms last longer, it's probably an allergy. And strep throat is a little bit interesting. It causes rheumatic fever in 1 to 3% of cases if those cases are untreated. Rheumatic fever is a really serious disease and causes heart disease, damage to heart valves that is permanent and debilitating. It can also wreck your kidneys. But here's the interesting and amazing thing. The antibiotic treatment of strep throat doesn't actually help get symptoms go away quicker. All the antibiotic treatment does is prevent those complications. So we try to treat people with strep throat to prevent complications, not actually to make them feel better. And you don't have to start that treatment for 10 days after the onset of the disease. So
isn't a lot of strep viral now too, though?
Strep is a particular bacteria. So sore throats are often viral, like strep throat is bacterial by definition, and strep throat, which is a very specific bacteria, 1 to 3% of those cases, 1 to 3% turns out to be at risk for rheumatic fever. We don't know who's who. That's why we start everybody on antibiotics. The use of antibiotics for streptococcal pharyngitis has basically eliminated rheumatic fever, rheumatic valvular heart disease in the United States. So when I went to medical school, the guy who figured this out was actually at my medical school. We used to see rheumatic fever all the time, and people had terrible congestive heart failure because their heart valves had been destroyed. And it was before valve replacement, so people were dying in their 30s and 40s because of the heart valve destruction caused by the bacterial infection. Once we started treating streptococcal pharyngitis with antibiotics, rheumatic fever has gone away in the United States. That is something that has happened in my lifetime, and it's actually quite cool. But it's this sort of partnership where somebody has to recognize they have a sore throat, they have to get to hopefully a primary care physician within 10 days. They get swabbed, their throat is swabbed, and we can tell whether it's bacterial or not, and whether it's the specific bacteria, the specific strain of strep. If so, then we start them on antibiotics and we prevent this disease. Sort of changed the course of human disease in the last 50 years. It's pretty amazing. But it doesn't mean that everybody with a strep throat needs to be in the emergency department. That's something that people in the primary care world do every day of the week. It's like we don't even have to think about it much. It's sort of part of getting dressed in the morning. So viruses and bacteria cause about 1/3 of same-day sicknesses, most viruses and bacteria can actually be controlled by the immune system. Bacterial illnesses often need a clinician's care and antibiotics, but can most often be cared for by a primary care person. And viral illnesses are often self-limited, but sometimes if there's serious symptomatology, that's when a primary care person can help tell them from bacterial illnesses and allergies. Obviously, folks in the ED can do the same thing. Just you don't really need the ED to do that. You need the ED for sepsis. You need the ED for meningococcemia. You need the ED for the rare cases of herpes, encephalitis. But those don't present as just a fever and a sore throat. Those present as prostration, sort of nausea, vomiting, can't get up. Sort of they look as much like a stroke or other cause of unconsciousness as they do like, a sore throat. They don't look at all like a sore throat. So, questions?
What exactly is rheumatic fever?
Rheumatic fever, I would have to look up the criteria. I used to know them, called the Jones criteria, actually, is an infection of the heart valves. It's actually, that's not right. It's the immune system's attack on the heart valve, an autoimmune phenomenon kind of akin to arthritis. So the immune system itself attacks the heart valves and destroys them. And that happens after an infection with a certain strain of strep.
So is it like autoimmune disease almost?
It is in fact an autoimmune disease, but it's an autoimmune disease that's incited by a bacterial infection. So you asked a great question, because it's actually, it's pretty complicated. But the cool thing is, somebody figured it out 50 years ago, and we basically made it go away. So if you guys ever want to do something really wild, spend a month in Central America or in Africa and see the disease burden that happens in those places, which is totally different from what we see in the United States. You see diseases, I spent a month in Kenya and a couple of weeks in Liberia, and I saw stuff I've never seen here. I spent, most of the month in Kenya, throwing lumbar punctures, sort of 3 a day for kids coming in with malaria. Thank God we don't have malaria here. That's a disease that you don't even want to think about. And there are others that, TB, shows up in ways that we don't know or remember. We've gotten rid of most tuberculosis in the United States. So we actually live in a pretty lucky world by comparison, because we don't have the burden of infectious diseases that other parts of the developing world have. Anyway, I think we're good. Let's, any other questions? Feedback on today's session, outside of the policy stuff. We can do policy stuff too. But was this useful? Helpful? You're going to see better looking people than me most of tomorrow. I'm going to be here for the first hour. My colleague Josh Gutman's going to be here for the rest of the afternoon. And then we're going to do stuff like this pretty much every day this week. We're trying to mix in some cases to kind of keep it a little bit interesting, and we're going to try to mix. We got a little field trip today, and we got one on Thursday. We'll walk through the new neighborhood health station. And then Friday, we got a little simple opportunity to show your knowledge. And we're going to try to create we've created a certificate that will get signed by a couple of people here and by Jason Rhodes, which will record your participation. And hopefully, as this process begins to develop in the rest of the state, as I'm pretty sure that it will, you guys will be recognized as the people who know this best and did it first. So thank you for what you do every day. Thank you for being here today. And then let's head to 39 East Avenue, where the parking is not good. So I would carpool if you can. And we'll meet in the lobby, 10 or 20 minutes from now, as soon as people can get themselves there. There'll be, 20 minutes there, and then we're done for the day. So thank you all.
My car gets hit,